Hello everyone, my name is Minh Hoang. I am a nurse at CVICU. Today would like to introduce you on my project. It's called Stroke Volume, a new vital sign for fluid resuscitations in critical care. So let's start with my idea. So I have a lot of patients in critical care, that's meaning very sick patients. When they come to critical care, we start a lot of fluid resuscitation phase. And then maybe if they not respond to that, I will start with the pressure. However, a lot of patients in um, critical care develop some hypothermia and AKI. According to Dave 2022, 22% of 57% ICU patients develop hypothermia and AKI, and hypothermia is the independent predictor of ICU mortality. So what is reduced? My question is like, how can we understand like we continue to fluid challenge or we stop and start the pressure? So some couple practice we use is the CVP to understand like the fluid responsive. But for many research, CVP is also known as like central venous pressure. Is not a good indicator to fluid responsive. And I would like to know about the value we can measure is called stroke volume, and it's really a good value or indicator to determine whether fluid is enough or the pressure should be used. So my project agenda today, I will talk about my presentations. I will talk about the CPP, why it's not a good indicator for fluid responsive. I will introduce the stroke volume. I will talk about what my current practice with the swan guns who we will use for measure the stroke volume. And I will introduce another device who can measure for stroke volume is called chance esophageal Doppler. And finally, I will talk about what is the next phase in my project. So central venous pressures or CPP is a measured blood pressure at the right atrium and vena cava. CPP is used a lot in critical care for fluid responsive with the normal range is 8 or 12. With the over the elevated elevate CPP, we can tell like they overhydration, over fluid, or it's very common seeing the patient with heart failure. For the patient with the low CPP, they can tell like they dehydrations and they develop some hypovolemia. So, and then the next one I will tell is about why limitations of the CPP in fluid responsive. From what I researched from many articles from 2005, 2008, 2013, or recently 2022, 2023, 24, we found very consistent the result. So no direct link between the CVP and hemodynamic response to fluid challenge. And only 50% of fluids administered guided by CVP are administered appropriately. And volume administrations often need to be repeated to maintain hemodynamic adequacy. For me, and then for really consistent life, fundamentally, the only reason to give a patient a fluid challenge is to increase the stroke volume. So, like, why give the fluid challenge? We saw the blood pressure is low, we gave a blood pressure. Give a fluid, the blood pressure is go up, and then we gave a pressure to maintain the blood pressure in the range, which is the blood pressure is related to stroke volume. I will talk more about stroke volume in the next slide. So stroke volumes is measured in milliliter of blood. The heart pump with each beat. The amount of eject of each beat is 60 to 130 milliliter. So stroke volumes can calculate it, and they have some formula. The first formula we can see right here is stroke volume is equal with the end diastolic volume minus the end systolic volume. Another one I would use in this case is cardiac output equal for heart rate to multiple with the stroke volume. However, the stroke volume have a three factor to affect to their stroke volume value. It's called preload, contractility, and afterload. So when I talk about a stroke volume, about a reload, afterload, and contractility, we use a lot of, I use the symbol is called a balloon. So let's think about the balloons when we talk about a reload. We can call a reload is a tank. The reload, that means like when you're filling the balloon, or we can call in this case for the heart is ventricular filling. So the blood volumes to filling in the blood in the ventricular chamber. The reload can measure by CPP, pulmonary artery wedge pressure, or the flow time is also called FTC. So if the reload is so low, we can call it hypovolemia. The next one is the afterload. So you look at the tip of the balloon. If we pinching the balloon tip, the amount of the air coming out is very little. When we open the tip a little bit, the amount of the air is coming out more. The afterload in here can consider as a pi. And what is the pi in the circulation? Is the blood vessel. So blood vessels have a diameter and a length. Diameter is also controlled by the brain and some chemistry in the body when we can constrict or dilate the blood vessel. So it will change the afterload. And how can you measure the afterload? We will measure by the systemic vascular resistance, or we can call it SVR. So that's why when you see a lot of patients with the systemic hypertension, the afterload is always high. That's why it's causing them a lot of problem to pump out the blood or increase the blood pressure. The last one I want to talk about is contractility, or we can call the pump, which is the intrinsic strength of the cardiac muscle. So just talk about like how we can squeezing the balloon. So if you squeezing strong, amount of blood is coming out a lot. If you squeeze very weak, the amount of blood coming out is not good. How can measure with the contractility? So we can measure by ejection fractions, or we call it EF, or we can measure by pressure volume loop, which called PV, or stroke volume. So in the patients like in the heart failure, the patients have very weak muscle, so the EF is very low. So back to this my idea. So I said like, what is the rule or the protocol or the guidance I would do to determine the fluid challenge or the pressure? So my rule and my proposed guideline in here by fluid challenge continue as long as stroke volumes is improved by 10% or more, and less. If less than 10%, we will start pressure based on the article I found in Moon et al. 2022 and from the Chase 2024 and Johnson 2024. So let's start with my guideline. So we start with the patients. We say, look at the patient. Is that the patient hypoperfused? How can we know a patient hypoperfused? We can tell about blood pressure. We can tell about level of consciousness, urine output. Did patient develop sepsis? How is the lactate level? So if the patient is in the normal, we continue to monitor the patient. But if the patient is have hypoperfused, and we say yes, the next one we for us is like, do they fluid responsive? Are they fluid non-responsive? And this one based on the stroke volume. So we will measure the stroke volume before we give the fluid. So after we gave the stroke volume, we gave the fluid, and the stroke volume improved by 10 or more than 10%, we will say fluid responsive. And we consider to the next one. How about the afterload by measure by the SVR? If they normal, we continue to give the fluid. If they low, and we continue to give the volume and basal pressure. The next one, if the patient is non-responsive, that means we gave the fluid, but the stroke volume is not improved by less than 10%. We continue to say, so if the patient is low afterload with the SVR, we gave a pressure. If the patient is low contractility, how we can know that one? Based on the EF, based on the history of heart failure, or the PV index. We will use the inotropy and the mechanical support. So that is the guideline I want you to use to determine is fluid responsive by the stroke volume, where we continue to fluid responsive, or we will stop in here. So I would like to talk about the current practice at my place. So at my place, we use the stroke volume only in open heart patients only. So it's also called is coronary artery bypass graft surgery or CABG. And then the device we use is Swan-Ganz, also known as the pulmonary artery catheter. So we use the Swan-Ganz or pulmonary artery catheter is very invasive device, and it has many higher risks, like for infections. They have arrhythmia, lung collapse, blood clot, bleeding, cardiac tamponade. How about other patients who not have a CABG surgery? Do we have any protocol? Do we have any guideline for that? Do we have any indicator for that? Nope, we don't have anything. We don't have any policy standard in this case. And some occasionally we use CPP. The doctor will come and say, yeah, give them fluid, give them pressure. Let's check the CPP and determine like fluids or the pressure. And the last one, like I told many times, CPP is not a good indicator in this case, and not really should use in critical care to the patients, because like it continues to keep causing many patients to experience hypervolemia and AKI, and increase the patient mortality and causing poor outcome. So however, I found in the one article very consistent. They say Swan-Ganz or pulmonary artery catheter shouldn't use in the very solely used and reliable for the CABG patient. But other heart condition or other critical care conditions, the Swan-Ganz or pulmonary catheters shouldn't use because it increases some risk for the patient. And then that means we cannot know the stroke volume. So how can it measure that? How we know the fluid responsive or the pressure? How we can stop or start the pressure? So for the next slide, I will introduce the next device. So the device I want to introduce in here is called transesophageal Doppler. This is the ultrasound probe in esophagus. If you know about the esophagus temp probe, this is the same way how you put insert that one to the patient and measure. And then this one, can you look at the monitor, you can see like you can measure the FTC, the stroke volumes, cardiac index, the heart rate, and the monitor can giving many for the hemodynamic data in here. And the next question for me when I look at that one is the esophageal Doppler giving the same data like Swan-Ganz? This is really concise, really reliable for me to use it. So I do a lot of research, and I found one thing: both Swan-Ganz and esophageal Doppler provide the same data, but the Swan-Ganz is highly recommended to use it in the CABG surgery patient only. So I'm moving on to the last one when I talk about wrap it up about my project. So I talking about like why CVP is not good. I introduced a stroke volume, and I proposed the guideline how to use a stroke volume for fluid responsive, and I introduced a device can measure the stroke volume, which is less evasive, and it can be measurable. So the next step for me, so like for my project, is starting with the phase 2. After my presentations, research, and propose the guideline, I would like to do some clinical trial at my workplace with my proposed guideline protocol, and it will be happen in 6 months. And I will start as phase 3 when I collect the data after the trial and do evaluations. What criteria I do in the evaluations, I will list some couple criteria right here. So like case of hypervolemia or AKI compared to before using the guideline, how effective of the guideline contribute to the patient outcome, feedback from the medical professional like nurse and doctor, etc. So after collect on the data and evaluation, I will read. I will look at back my guideline, correct it, put in more information, and establish the new guideline with the support from the management and promote that one to be a protocol or policy for fluid responsive for the patient in critical care, except the patients with CABG surgery. This is my reference, and I would like to thank you to Mr. Johnson from Illinois and Mrs. Chase from Arizona. There, I met both of them at the NTI 2024 in Denver, Colorado, which is the conference for critical care nurse from organized by American Association of Critical Care Nurse, and they talking about a lot about hemodynamic, and they gave me some inspiring about the stroke volumes. That's why I start with this project, and it make me feel learning more about the material, changing my mind about the way I practice, and inspiring me to do this project. So thank you for that. And that's everything. Thank you.